Okay, very cool to be here. Really appreciate the opportunity and to be able to share these lessons learned from the joint trauma system. Oliver asked me to really talk about why is it that a lot of the literature on pre-hospital transfusion isn't moving us in the right direction, and so we're going to kind of go there. First off, I do not speak for the DoD, nor any part of the Defense Health Agency, and I have no conflicts of interest, except I do have an interest in conflicts. So, talking here a little bit about the military trauma system, I think most people in this room are at least somewhat familiar. We talk about the trauma system covers everything from prevention of injury through to recovery, and there's a lot of moving pieces in between there. It's very interesting to me how all of these pieces fit together and how it's so important that we need to sustain that chain of survival all the way through. Every single person has to do their part, and it has to happen within the right time frame, not just whenever you can do it. The joint trauma system is the part of the trauma system that is really focused on performance improvement, on how do we get better every single time. How do we collect data, put it into the trauma registry, analyze that data for the purpose of performance improvement, and then write the clinical practice guidelines that will contribute to that continuous cycle of improvement. That's really the mission of the joint trauma system. So I'm going to talk a little bit about some of the analyses we did when I was at the joint trauma system, and then we'll talk about what has followed on in the civilian literature. So in 2012, I was deployed downrange as the Joint Trauma System Director, which is the Chief of Trauma for the downrange teams in Afghanistan. And in 2012, while I was downrange, this study came out. This was, on the military side, pretty famous study by Colonel Eastridge that looked at all of the deaths that occurred in the first 10 years of the Middle Eastern conflicts, 2001 to 2011, over 5,000 deaths. All of them had an autopsy. And what that study shows is that about 90% of the deaths occurred before the patients got to the hospital. And I'm a trauma surgeon. I was working in the hospital. We're working our butts off day and night, doing brain surgery, limb salvage, vascular surgery, working around the clock in the ICU, trying to keep the patients alive. And 90% of the patients aren't even getting a chance. And, that was really news to me. And I never actually really thought about it before. And so that completely changed my approach to trauma patients. And to this day, I think I can save more lives by training medics than I can by doing trauma surgery. So getting to the registry analyses, we started getting really interested in this issue of timing. Things like timing of blood transfusions, timing of surgical team handoff, arrival to a surgical team, timing of craniectomy for patients that need brain surgery. This brings me to this concept. Life-saving interventions delivered too late do not improve survival. That is so obvious, so obvious. And I think that we all understand this, we all realize this, but how is it that over and over again in the trauma literature, in the emergency medicine literature, over and over again, we keep proving that the interventions that we're doing are not saving lives, but we're probably delivering them too late. Brian yesterday was talking about delivering adrenaline too late. It's everything that we do, minutes matter. And so let me just talk a little bit about survival curves to help us all get on the same page. This is a 30-day survival curve for severely injured trauma patients in Afghanistan, and it's about over 5,000 patients, 5,269 to be exact, who were fairly seriously injured with the AIS score of 2 or greater. And the remarkable thing about this graph is that the whole entire first part of it is going straight up. It's vertical. That's where most of the patients die. Almost all the patients die on the first day. After that, the curve is pretty flat. There's less than 7% of the patients die after the first day. We looked at the first 24 hours. Not all the patients had time. So about half of the patients in our registry had the time of injury, all the times of events, time of death. And in this case, you can see that 68% of all deaths occurred within 1 hour. 90% of all deaths occurred within 4 hours. And then only about 10% of the deaths occurred after the first 4 hours. Another way of saying this is if you survive 4 hours, your chances of surviving are 90%, they're pretty high. If you survive the first 1 hour, the longer you've survived, the more likely it is that you will continue to survive. So started trying to drill down on the critical time windows. We don't have time to talk about all of these today, but we all know that external bleeding control, clear the airway, needs to happen really quickly, like within minutes. Initial blood product transfusion, that's going to be what we're focusing on here. But after that, we still need to have handoff to a surgical team, followed by the first emergency surgery, and then taking care of the brain. So, looking in on what did our military data show on time to transfusion. This study was published in JAMA, and surprisingly, it's a really small retrospective study looking at blood transfusions, the first round of blood transfusions that were implemented with the dust-off, our Army medevac that was implemented starting in 2012. And I think part of the reason this was able to get published in JAMA is this is a really unique population that existed within this area of operations at a very specific time, and really is unlikely to occur in any other sort of area. So this was 2012 to 2015. This is our initial experience with pre-hospital transfusion on the helicopters. And it was a concurrent cohort. So if you can see in this picture, in this red and blue graph here, some units, some medevac teams were able to, starting with one team at FOB Eddy in April, and then kind of moving out to more and more locations, we were at the same time having the capability to transfuse blood at certain locations. Other locations did not. So we were able to compare at the same time in the same AOR patients who did and did not have the chance to receive blood transfusion. In the study, there was 502 total patients, of which there was only actually 55 who did receive the blood transfusion. And this is a little bit complicated, but it goes into the matching process. And I think when we start talking about the methods of some of these other studies that are out there, the methods of how you do these analyses are incredibly important. So the patients met 3 criteria. They were military injured in Afghanistan, they were alive when the medevac arrived, and they had one of the indications for pre-hospital transfusion according to the CPG at the time. Then they were matched to non-recipients. And this matching process is very, very, very essential, and they can introduce a lot of bias into your study. So we only use matching characteristics that the medic could see, so that it was something that was visible, like number of amputations. You can see that. Did they have an indication of shock? Yes, no. Those were the matching factors, and there were 355 matching non-recipients. The ones that didn't match were either too mildly injured or too severely injured to have a matching pair. So what do we find? All right, so this is a survival curve, mortality curve, my bad. This is a mortality curve showing in green those who received transfusion, and in red, those who did not receive pre-hospital transfusion. And what we found is the transfusion recipients had significantly better survival. You can see the hazard ratio is 0.26. It's a really low hazard ratio. And so this was a very strong signal that the pre-hospital transfusion recipients did have a better survival, which continued out to 30 days. So if they survived that first day, they basically continued to survive out through the 30 days. Again, hazard ratio of 0.39, strong signal. But then what we noticed, I think is really key, that I would love to see it repeated on the civilian literature. We noticed, so the red dots represent patients who got pre-hospital transfusion. I'm sorry, the blue dots, pre-hospital transfusion, red dots, in-hospital transfusion. We noticed that some of the patients got to the hospital and got an in-hospital transfusion faster. How does this thing work? Is, I see it right now. It's all right. The red dots are, some of the patients got to the hospital fast enough that they got their in-hospital transfusion faster than some of the patients who had to wait longer to get a pre-hospital transfusion. And really what's most important, the patient doesn't care if they're on a helicopter, on the ground, in a hospital. They care when they get the transfusion. It really does not matter how long, or it does not matter where they are, it's how fast they get it. And so looking at time to transfusion specifically, we found that those patients in blue who got transfused within 15 minutes of the medevac takeoff had a significantly better survival compared to those who got transfused later than 15 minutes, which averaged to be about 36 minutes from the time of injury. And this is a hazard ratio of 0.17. So again, strong signal. But even more fascinating, if they got transfused even 5 minutes later or longer, there was no difference in their survival. And so this really got us started to think that it really is a matter of minutes. Minutes matter. A 5-minute delay to transfusion can make the difference between whether that patient has any benefit from that transfusion or not. And so the conclusions of the study is very specific to the military in this trauma system in Afghanistan and the conditions that were there, but definitely supported pre-hospital transfusion under those conditions. And it suggested that there is a timeline involved, roughly 36 minutes in this study. So before we go into the civilian literature on this, I want to bring up my favorite anecdote. I'm sure a lot of you have heard it if you've heard me speak before. But this will get us in the mood of analyzing the literature. So this is Dr. Wald. He's an engineer who was helping the British and the Americans during World War II. And what he was doing was helping to analyze the damage to the aircraft and try to figure out how to up-armor the aircraft and improve survivability. This is what they found. These are the aircraft. They mapped out all the damage to the aircraft as they returned to the airfield. And Dr. Wald concluded the obvious: where do we need to up-armor this aircraft in order to improve survivability? Of course, it's the engines and the fuselage, right? Every place where there's no red dots, because those are the aircraft that didn't make it back to the airfield. And this just really kind of brings up the idea of survivor bias. And in our trauma literature, our emergency literature, this problem of survival bias sneaks into our literature in so many different ways that it actually can reverse the results and change the reliability of our results. So this refill study got a lot of attention. It's basically a prospective randomized trial, pretty big. It's in the UK. And I mean, multi-center trial, spent about $4 million, and patients were randomized to receive up to 2 units of red cells, 2 units of plasma. It was Lyoplas, and versus a liter of normal saline. Like, I don't even think normal saline is the standard of care. We use that as sort of like if we want to make our patients even more acidotic. So I think, like, how is it possible that these patients would not benefit from this intervention? And so their outcome was a composite of mortality and lactate clearance, and included patients in hemorrhagic shock. 432 patients, about half got the red cells and plasma, and half of them got saline. Stopped early due to COVID. Yeah, but what they found is there's essentially no difference. No difference in mortality, no difference in failure to clear lactate, like no difference between these two groups. Like, how is this possible? And then, I started looking at more closely at this study, and it just made me really realize, like, time from EMS call to arrival of EMS was about 30 minutes. So they're starting 30 minutes. This is not even from the time of injury. This is from the time of EMS call. So, more than 30 minutes. Time from EMS arrival to the first fluids, another 26 minutes. And then time to hospital arrival, mean of 90 minutes. And we say mean of 90 minutes, that doesn't mean all the patients are getting there within 90 minutes. It means half of the patients is taking longer. That's the mean. And so all of this, and this is a super sick group of patients with a mean systolic blood pressure of 73. That means half the patients are lower than 73. So super sick group of patients, and they're just not getting this intervention fast enough. So what did we just prove here? Life-saving interventions delivered too late do not improve survival. We spent $4 million to prove this. So let's talk about a couple other studies. So surely we learned our lesson from this study. Then we get the PAMPER trial. This is published in the New England Journal, which included giving 2 units of thawed plasma versus standard of care. And the weird thing about this study is that half of the ambulances, their standard of care included red blood cells, and the other half had only crystalloid. So there was like a lot going on in this study where it just like 2 units of plasma on top of either red cells or crystalloid. And they looked at mortality at 30 days and included patients in hemorrhagic shock. So 501 studies, 230 got plasma, 271 received standard of care. In this study, there's a 10% significant difference. Hard to know why, but you can see that the median pre-hospital time was 40 minutes, so it's still pretty long. 39 minutes from if they're transferring from POI to the hospital, and but for whatever reason, this study gets a different outcome. So we're like, well, we got to keep studying this. So then you get the combat trial, similar type of trial where they give 2 units of plasma, but this was done at a single center in Colorado. And the standard of care included only saline. There wasn't any group of patients in there that were also getting blood. And so, but they did seem to have pretty fast response time. Injury to hospital time was about 28 minutes for the plasma, and they were actually carrying frozen plasma and like de-thawing it right on the ambulance and giving it. And they said that maybe caused a slight delay in the transports arriving to the hospital somehow. There's like 4 minutes longer for the patients who got plasma. But in this study, the plasma recipients had a slightly higher mortality, which was not significant. So similar type of study with the opposite results. And I thought a lot about why these studies are just kind of all over the place and just showing different things. And what I really think is going on here is that as they do the analyses, they're not taking into account the time to transfusion, the time to intervention. They're just comparing the entire group of patients that got pre-hospital transfusion to the entire group of patients who did not get pre-hospital transfusion without any regard to the time. And even if they say the average, time to first plasma unit was 24 minutes, again, half of the patients took longer than 20. Took significantly longer. This 24 is actually the average time. So if they were to reanalyze all of these studies, we might get different results. 2 more studies to just mention. This one, I thought, this is starting to get after the question. They said time to first whole blood transfusion and survival following severe hemorrhage after trauma. But what happens here? here in red, excluded pre-hospital cardiac arrest and deaths within 1 hour of ED arrival. Who are we trying to save here? Those are the people. They excluded all of them. Nevertheless, they did show a benefit with more timely receival of whole blood, and you can see on the left side of the screen there, the 24-hour survival. In the yellow line on top is those who received whole blood earlier and compared to those who received whole blood later, and they showed better survival with those receiving whole blood earlier, in spite of excluding all the first 1 hour of deaths. And then finally, we have this paper. And I think this paper is really getting after it. This is where we need to start thinking. Time to early resuscitative intervention associated with mortality in trauma patients at risk of hemorrhage. They basically took two of the previous studies, the Pamper trial and the STAMP one, which I didn't mention, but there's been several studies looking at this. And in both of those studies, the standard of care group included red blood cells. And so you have a cohort of patients that got just plasma. There's another cohort of patients that got just red cells. There's another cohort that got plasma and red cells. And there's another cohort that got just saline. And so really there's 4 different interventions possible in this trial. And so they basically looked and reanalyzed these two trials based on time to intervention. And the 3 interventions that they looked at was plasma, red cells, and they also include TXA. And what they found is every 1 minute delay to intervention, each of those interventions, was associated with a 2% increased odds of death at 30 days. And this is their graph. You can, on the top, red cells, let's just say 24 mortality per minute increases 1.047 odds of death. Same for plasma, same for TXA. Minute by minute, every single minute delay increases your odds of mortality. And so I think that, honestly, this particular study is finally getting after the question of pre-hospital transfusion. Needs to happen as quickly as possible. Is 30 minutes the threshold that there's no longer a benefit? I don't think we have, other than the one retrospective military study, we really don't have good data on that. I think by reanalyzing some of these existing trials, we could probably get the answer because they have the times available. They just didn't include them in the analysis when they did that. And I think I've also thought about things like mountain rescue or these type of search and rescue situations where you really have a delayed response. And we really have no data for like what is the benefit of blood transfusion in those situations where the patient's already survived a certain amount of time. All I can say is I do believe that if the patient has evidence of blood loss and has the hemodynamic indications to receive transfusion, even though they've survived, probably still is indicated. We just have yet to be able to quantify what the benefit would be in that scenario. So this is how we think of our trauma system, is basically a planning factor for the times, our goals. And so our goal is to control massive external hemorrhage and clear the airway, make sure the patient can breathe within minutes, not specifically quantified, like whether is it 3 minutes, 4 minutes, certainly the faster is better. Our goal is to get blood transfusion on board within 30 minutes, try to get them to a surgical team where they can get damage control surgery within 1 hour. And then we didn't discuss the neurosurgery, but the neurosurgery outcomes are improved if you get to a brain surgeon within 4 hours. So and that's how we're planning our trauma systems. We know we may not meet those timelines, but if we don't, we know that more people are going to die. This is my email address if anyone has any follow-up questions they want to get a hold of me for. And I'd be happy to answer any questions.